Okay, I want to talk about anesthesia, and there are a lot of patients of ours who are kind of frightened of anesthesia. They say, I have no worries about your surgery, but I'm kind of worried about the anesthesia. And what we tell people is, you're worried about the wrong thing. The thing to worry about is the surgery and not the anesthesia. But let's talk about anesthesia, because there are some risks with anesthesia. Going to sleep and waking up can be very serious. It's more serious the heavier you are. The more dangerous it is, the heavier you are. And so we want to talk about the drugs and the character and the type of anesthesia. And around the world today, in the United States and in most other countries, if you get anesthesia, you're going to get a combination of a gas anesthetic and narcotics for pain. And that's basic. And both of those drugs, the gas anesthetics and the narcotics, have some significant complications and risks. Both of them have the same two issues that I want to talk about this morning. One is annoying, unpleasant, and difficult and bothersome, and the other one is potentially deadly. Number one is the gas anesthetics can cause nausea and vomiting. It's so well described after gas anesthetics, it's got its own abbreviation, PONV, for postoperative nausea and vomiting. 1 person out of 3 who breathes the gas anesthetics will get nausea and vomiting and throw up and have a difficult time with it. That's unpleasant, it's difficult, people who've had it hate it, but it's not deadly and usually get through it. The other complication the gas anesthetics can have is that they are lipophilic or fat-soluble chemicals, so that they can dissolve into your fatty tissue, and unexpectedly in the postoperative period, they can diffuse back out of the fat into your bloodstream and cause you to have what we call respiratory depression. And if it occurs unexpectedly in the recovery room or afterwards in your room, you could decrease your breathing a bit from the residual anesthetic, plus be heavy, and plus maybe have some pain medicine on board, and suddenly you don't breathe enough, your oxygen gets low, and you can get in trouble. In fact, you can have respiratory arrest and even a death. So gas anesthetics can cause postoperative nausea and vomiting, which we don't like, and is dangerous and unpleasant. And then you can also cause potential respiratory depression, and with that, emergent reintubation and even death. So gas anesthetics, although they're wonderful and commonly used, have those two problems. Now I'm going to talk about the other commonly used drug in most people's surgery, and that is the group of medicines that you know as morphine and other narcotics. Narcotics are wonderful, they're superb pain relievers, but again, they have two complications. One, like we talked about, for the gas anesthetics, they cause nausea and vomiting. So if you've ever taken codeine, if you've ever given medicines, you know that the narcotics can cause you to have nausea and vomiting. And again, that's no fun. Especially if you just had abdominal surgery. But the more dangerous complication, just like for the gas anesthetics, is the narcotics decrease breathing. So if you've ever heard of someone dying of an overdose of narcotics, a drug addict or somebody in the hospital or somebody getting pain medicine, their death is caused because the narcotic drops the drive to breathe. It's a respiratory depressant. If you take the gas anesthetic, which can be a respiratory depressant, and the narcotic, which can be a respiratory depressant, and a morbidly obese patient who has limited lung function already, excuse me, that combination can be deadly. So we don't like it. And we use a different flavor of anesthesia that is much safer and spares the use of spares the use of narcotics and anesthetic gases. What we use are a combination of intravenous drugs, which don't cause nausea, more rapidly are eliminated, don't sneak out into the fat so they can't sneak back in postoperatively. And then we use some drugs to take away your pain that do not cause respiratory depression. So we have found that the narcotics work by finding a chemical receptor in your brain where the narcotic goes and fires that receptor. And we said, gee, I wonder if there's some other receptors in the brain, and we found two. The alpha-2 receptor and the NMDA, or the N-methyl-D-aspartate receptors in the brain, and we can activate those receptors using an old drug that's been around forever called ketamine, and a new drug called dexmedetomidine that's brand new. And about 1.5 years, 2 years ago, we started using the new technique of opioid-sparing anesthesia, and what we demonstrated is we decreased pain, nausea, the need for nausea medicine by using that new technique. So we're real happy with it. Our patients who've had that new technique have generally been happy with it, and we think it's a good and safe technique.